Hello everyone. Do you wish to be an excellent dentist in your clinical practice? The only important criteria which demarcates a mediocre dentist from an excellent dentist is their ability to do the excellent and accurate diagnosis. Diagnosis in endodontics can be broadly divided into 4 different stages. The history, listening to the history of the patient, doing a good clinical examination, then doing a vitality testing, and then proceeding with a radiographic examination. In the first part of this presentation, I have explained about the history and the clinical diagnosis or clinical examination. If you haven't seen that part, I would ask you to watch that part before proceeding with this presentation so that it will be easy for you to understand. Today we shall continue with the vitality testing. The most important factor or the point that you have to understand while doing a vitality testing is there are 2 types. That is the vitality testing versus the sensibility or the pulp sensitivity testing. Most often, whatever we call as a vitality testing are basically pulp sensitivity or sensibility testing, and they are not true vitality testing. The only 2 different types of pulp vitality testing are the laser Doppler flowmetry and pulse oximetry. Unfortunately, both of these techniques have not yet developed to an extent that the devices are not available for diagnosis in clinical practice. So, whenever we say a pulp diagnostic test as a vitality testing, it is not a true vitality testing because we are not using it. The second important point that you have to understand is all the vitality testing are a subjective testing. What is meant by this subjective testing? We are going to do a testing and we are going to ask the patient, do you feel any sensation? And if the patient says yes, we take it as a positive response. If the patient says no, we take it as a negative response. So let's think about a patient who is quite apprehensive and may not be there is a sensation when we are doing the testing, and if the patient says that yes, I feel a sensation, then it is going to be totally wrong. So none of this pulp vitality or pulp sensitivity or sensibility testing, none of these can be considered as a 100% accurate testing, and all of these testing are just dependent upon the patient response and not an objective value obtained by this testing. So we have to do multiple testing and we have to rely on multiple criteria like the history correlating with the clinical examination, correlating it with the radiographic and vitality testing. So there are no single testing can be considered as the best testing. So basically the vitality testing which we commonly practice in our clinics can be divided into 3 types. They are using a heat called as a hot or a heat testing, then we can use cold for as a cold testing, and electric pulp sensitivity testing. First one, to understand what is a heat testing is we are going to apply some heat. So whenever we are applying heat to the teeth, it will be taken or absorbed by the free nerve endings of the pulp and a sensation will be created. So that can be used for checking whether the neural connection to the pulp are intact or not intact. If it is intact, then we could say that yes, the pulp could be vital. How to do this testing? The easiest way is we can use the GP sticks, not the GP cones which are used for obturation. The GP sticks which are available, which can be heated over a flame so that it will soften. What's the first step to do? We have to test it over a normal tooth, not the tooth in question at first. So we have to test it over a normal tooth. Once we establish a response, for example, after 3 seconds there is a response elicited by the heat, we can keep that 3 seconds as a standard or a reference value, and then we have to keep or repeat the test in the same manner in the tooth in question. If there is a sensation which is felt, for example, in 1 second, we would say that it is an early response. If it is felt in the 3 seconds as in the normal tooth, then we can say that it is a normal response, or it could be felt in 5 seconds, we can call it as a delayed response, or if there is no response at all, even after applying for a prolonged time duration, we could call it as a no response. Whenever there is an early response, there could be some problem in the tooth. When there is a normal response, there will be no problem, and if there is a delayed response, probably there might be a problem, but the chances are quite less, and if there is no response, then the tooth definitely has some problem. Okay, so the alternative to use a GP stick for evaluation is, we can also use the thermoplasticized injectable gutta-percha. We can inject a little of the material over the normal tooth. We can establish a common response, and then we can use it over the tooth in question. Again, we have to understand that it is not a normal value for all the patient. For each patient, we have to calibrate it, and then we have to check with the tooth in question. The second testing, which can be considered as more reliable compared to that of a heat test, is the cold testing. The commonly available material which is used for cold testing is ice cubes or ice sticks, but a better technique for doing the evaluation is using a endofrost, which is ethyl chloride spray, which has a temperature of around -50 degrees Celsius. And what we can do is, we can take a small cotton pellet, or we can take a small cotton swab, and we can spray this material a little. Then you can place it over the normal tooth, establish a response, just write it down after how many seconds there is a response which is experienced by the patient. After that, we can test it in the tooth in question. Then we will come to know whether there is a early response, normal response, delayed response, or there is no response. The biggest advantage of doing a cold testing compared to that of heat testing is, the cold testing can be used even though there is a tooth which is having a crown. For example, let's take, if there is a tooth which is having a crown, then the clinical examination may not be very good, because we cannot examine what is there under the crown, and the radiographic examination will also not be really helpful, because in a radiograph we cannot see actually what is there inside the crown, and in all those situations cold testing can be really helpful. Compared to the other types of vitality testing like the hot test or the electric pulse test, cold testing is very reliable. So if you want to grade the vitality testing, I would vote for the cold testing as the most appropriate and accurate one. The third one we are going to see is the electric pulse testing. So this electric pulse testing is a reasonably good equipment for doing the evaluation. The location that we have to keep for electric pulse testing, or maybe for the heat testing or cold testing, for anterior teeth, we can keep it at the junction of the middle and the incisal third, and for a molars, we can keep it over maybe the occlusal and the middle third junction, maybe close to the mesiobuccal cusp of a molar, in that region. So that area can be considered as the area which is most reliable while we are doing this test. While using a electric pulse testing, the common mistake that everyone does is, we have to use a conductive media. Most commonly used conductive media is a toothpaste. So we have to apply a little toothpaste or any other electrically conductive media in the tip of the instrument or in the area where we are going to evaluate. Then we have to use a electric pulse testing. Again, this electric pulse testing, in the similar manner, we can increase the electric current depending upon their response for establishing the normal tooth. And after doing that, for example, at a value of 7, we have established a normal response. Then we can evaluate the tooth in question, whether there is an early response, normal response, delayed response, or no response. So using this electric pulp testing, heat testing and cold test, we can come to a conclusion that if there is no response with all of these three, then we can say that the tooth is non-vital. If there is an early response with all of these three, then we could say that the tooth has an hyperactive pulp, for example, an irreversible pulpitis. And if there is a delayed response, then it could be a presence of a calcification, or if there may be a more of a tertiary dentine deposition, or in case of a old patients, or if the patient has a very good pain tolerance, in all those. So whenever it comes to be a delayed response, we cannot make a conclusive diagnosis whenever we are using this type of test. Then comes the anesthesia test. Maybe there are many situations where we cannot differentiate whether the pain is from a maxillary teeth or a mandibular tooth. So in those situations, an anesthesia test may be helpful to differentiate which arch the pain is coming from, and other than that, it cannot be considered as a very reliable test. Maybe academically it is quite important, but from a practical point of view, it cannot be considered as a very reliable test. And the last test that we are going to see is to do a test cavity. Again, this is somewhat in common practice, but truthfully, in my clinical experience, whenever there is a tooth which is symptomatic, and if you are preparing an cavity with the burr, the vibration from the burr itself can create a sensation, and in case of an apprehensive patient, even if there may not be any sensation, the patient could say that yes, I am feeling the sensation. Anyhow, we have to apply rubber dam, and for applying rubber dam we have to anesthetize. So I do not say that test cavity can be considered as a very reliable or a modern way of testing a patient to check whether the tooth is vital or non-vital, and I do not recommend it. Without using a test cavity, we should be able to come to a clear-cut diagnosis. So these are a little about the vitality testing, about finding out whether the tooth is actually vital or non-vital. So the last part of this presentation is about the radiographs. After finishing the radiograph, I will summarize and I will give the clear-cut points that which are quite important for everyone to remember while doing clinical diagnosis. While doing the radiograph, there are 4 types of radiographic examination which can be helpful to make a radiographic endodontic diagnosis. They are intraoral periapical films or digital radiographs, then bite wing radiographs, the panoramic radiographs, and a CBCT. Looking at this, the IOPA, that is the intraoral periapical radiographs, can be considered as the most commonly used radiographs for doing radiographic examination for making an endodontic diagnosis. They are very good. With the advancement of the RVG, it has become much more easier, and I would say that we should be able to know how to take a proper radiograph and examine it properly. And coming to the bite wing radiographs are extremely helpful in case when there is a crown. If there is a full coverage restoration and if you are taking a IOPA, the crown is going to block most of the structures and we cannot make any useful findings. But instead, if you are using a bite wing radiograph, it may give more details about the margins of the restorations in many clinical situations. Also, we should keep something in our mind. Whenever there is a full coverage restoration or whenever there is some restorations or of any type, then we should prevent or we should avoid using the image enhancements. For example, whenever we take a radiograph while doing a root canal treatment, we will do some form of image enhancements for seeing the periodontal ligament, the extent of the file and the PDL space and everything. But we should never do that enhancement while doing diagnosis. So that can be used as a treatment. While doing treatment, we can do that. But before doing a diagnosis, because even if there are some slight changes, it will be magnified when we are doing image enhancements, and it could lead to probably a wrong diagnosis. Especially it might look like a proximal caries, but actually it may not be. So do not do any image enhancements while doing an examination or diagnosis with any of these radiographs. OPG or the orthopantomographic images are really helpful when there are multiple complaints, but it is usually for a preliminary diagnosis it is helpful. CBCT is a very helpful radiographic procedure, especially in case of anomalies or in case of fractures, or when we are not able to do a proper diagnosis, then we can go for a CBCT, or in case of failed root canal treatments. For example, if you are suspecting there could be a miscanal, in all those situations, for diagnosing these clinical situations, CBCT may be really helpful. So basically when you are seeing a radiograph, we can use radiographs for diagnosing caries while doing an endodontic diagnosis. We can look for the secondary caries, or we can look for the old restoration, the integrity of the old restorations, and if there are some secondary caries underneath, then we can see whether there is any periodontal ligament changes or widening or discontinuity, or in case of ankylosis, this PDL space may be missing. We can check that. Then we can look for the probable pulp involvement again in a OPG, in case of a periapical radiograph. It might look like an pulpal involvement, but basically it may not be, especially if it is a buccal extension or a palatal extension caries, or if it is a buccal pit caries, then it might look like a pulpal involvement, but basically it may not be. And even if there is an old restoration, it might give an impression that it is quite very close to the pulp. In all these situations, it is better to go for a bite wing radiograph. So bite wing radiographs are really helpful, which is often omitted in the endodontic diagnosis, and we say that no, it is not a good diagnostic procedure, but actually bite wing radiographs are extremely helpful while doing an endodontic diagnosis. Again, periapical lesion, I don't think anyone needs any separate explanation for that. And the important ones are the anomalies and looking for the anatomical structures. When you are early in your clinical practice, whenever you see anything which is devoid, it might look like an abnormality. So there are many anatomical structures, like especially the mental foramen between the two mandibular premolars. We have to be extremely careful while making a diagnosis, because a periapical lesion of a mandibular premolars or maybe the mental foramen both might give a similar look in a radiograph, which we have to be very careful about it in differentiating. And coming to the anomalies, actually the anomalies are much more than what actually you think about it. So the anomalies, so dense invaginators, you can see in this, it clinically it might appear like a very normal tooth, but actually if you take a radiograph, you can see that this is a dense invaginators and had undergone treatment, and we can see that. So just by looking at the first appearance, it looks like that something is not correct, but the incidence of these anomalies are more in clinical practice. So only if you are observing with your eyes open and with knowledge of these anomalies, you will be able to make an easy diagnosis. If you are considering the mandibular first molars, the MP2 canals, I have already made a separate video how to locate the MP2 canal. I will put a link in the description for that also. Just watch that video also, it will be really helpful. The incidence of the MP2 canals is overlooked in many clinical situations, but the incidence of the MB2 canals are too high, or they are almost always present, and we have to pay attention even in the radiograph. Always keep this slogan in your mind. Whenever the appearance of the tooth or the roots are bizarre, or it is a hazy appearance, then we can suspect some form of extra canals or some anomalies or something is there inside. So we all come to this, you all would have heard this, the enigma to endodontist. The mandibular first premolars are called as the enigma to endodontist because of their variety of the different appearances, having one canal, two canals, three canals, and all these anomalies are quite common in case of mandibular first premolars. Whenever we see this fast break appearance in a radiograph, we should appreciate that there is something is not correct and we should pay more attention. Here you can see that there are three canals in this single rooted mandibular premolar, and diagnosing it before starting with the treatments is very essential. Then we can see that the incidence of the radix entomolaris are too high. Actually, if you are it's almost 6% in South Asian population. So it is too high whenever you are doing this. But actually, with eyes closed, and if you are looking at the radiograph, you may not be able to appreciate radix even when it is present. So we should pay more attention. Maybe out of 100 mandibular first molar root canal treatments, maybe for around 5 to 10 teeth may have an extra root. So it is very essential. Each radiograph of a mandibular first molar should be examined whether there are any extra roots. Okay, then there comes the mandibular second molars, so the C-shaped canals. If you are looking at this radiograph, it looks like exactly normal. There is nothing anomaly that you can look, but actually it is a C-shaped canal with only one wide canal which is connecting or like a circumferencing from mesial to distal. So the C-shaped canals are also quite common, and we should pay attention, or we should examine with a clear-cut evaluation while doing this. So then comes in radiographically, we should look for a vertical root fracture. Again, there are many requests for how to diagnose a cracked tooth. Okay, so I will make a separate video on how to diagnose a cracked tooth with the help of a tooth sleuth, and the technique for diagnosis and the clinical examination and all those. I will make a separate video. The diagnosis of the vertical root fracture, which is quite common than actually what we think. So whenever the patient comes with an unknown problem and there could be pain, especially in case of a root canal treated tooth, it could be a vertical root fracture. In the clinical examination, I told that we should use a periodontal probe, and if there is a deep pocket at one location, then it could be a vertical root fracture. Again, whenever you see a vertical root fracture in the radiograph, it may have an inverted J-shaped radiolucency. Here you can see that from this area to, if you are looking at this furcation area, you can say that it has a J-shaped radiolucency. Whenever there is a J-shaped radiolucency, we can suspect that there is a vertical root fracture. Then calcifications. So calcifications, although it may be very common, but most calcifications can be negotiated easily. So again, for calcifications, I would say that if you find it quite difficult, you can go for a CBCT, because CBCT gives a clear-cut idea about calcifications. Again, maybe in another video, we can see about the calcifications and how to diagnose calcification and how to evaluate in a CBCT, how to negotiate and how to treat the teeth which are having calcifications. And the next important thing that you have to look in the radiographs are the presence or absence of a open apex, especially in teeth which have undergone trauma, or maybe in case of young patients, and root resorptions. So these are again much more common. Root resorptions are common in patients who are undergoing or undergone orthodontic treatments, because of the application of force, there could be root resorption. Again, it should be taken into consideration. So as I mentioned before, whenever there is a teeth with a crown, do not go for an IOPA, always go for a bite wing radiograph. It is going to be very, very helpful. And among the anatomical structures, the only structure which is endodontically very, very difficult to make a difference is the mental foramen. Mental foramen will be present between the mandibular first and the second premolars, and if you are taking a radiograph with multiple angulations, if there is a periapical lesion, it will be always present close to the tooth apex. If it is mental foramen, if there is a straight angulation, there is a mesial angulation and the distal angulation, the mental foramen will be moving from one location to the other, but if it is a periapical lesion, it will not move. So we can differentiate that. So coming to the conclusion, I will summarize what are the important points that you should keep in your mind. First, while doing the history evaluation, whenever the patient gives a sensitivity to sweet, it is in the outer enamel or the almost close to the dentin enamel junction. Whenever there is sensitivity to cold, then we can say that it is almost in the middle of the dentin. Whenever there is sensitivity to hot, and we can say that the caries has extended close to that of the pulp, almost very, very, very deep decay. And whenever the patient says that whenever I eat food and the food gets impacted inside the cavity and I get pain, we can say that it has almost touched the pulp, but the tooth is still vital and probably a reversible pulpitis. And when there is a pain while sleeping, if that was the patient's complaint, then it is definitely irreversible pulpitis. Root canal treatment may be needed. The tooth is mobile, and suddenly it has become mobile, and or the tooth is extruded out of the socket, then we can say that it is periapical abscess, which is the pus is extruding the tooth out of the socket. Whenever I clench the tooth, the pain get relieved, again it is periapical abscess. And if the patient complains that whatever I eat, the food is getting impacted, probably it will be a class 2 dental caries. And while doing clinical examination, if you are using the 3-way syringe, and if there is a sensitivity to air spray or air and water spray, the tooth is probably vital and root canal treatment may not be needed. Palpation of the periapical region and the patient get pains, the tooth is non-vital. The percussion, use it very carefully. Use a fingertip to percuss, and if there is pain, check for vertical percussion versus a lateral percussion. And if there is a pain when the patient is biting over the tooth slot, then it could be a cracked tooth. And keep it in mind, root stems usually will not create any pain, like extreme pains or severe pains are not usually a sign or symptom of root stems. And if there is a sinus tract, trust me, the chances for the pain are almost never. So if the patient is coming with extreme pain, and if you diagnose that there is a tooth which is having a deep decay and there is a sinus tract, you should look for another tooth, and that tooth may not be the reason for that extreme pain. The most common areas for the hidden caries are the buccal surface of the maxillary and the mandibular third molars. Always we have to pay attention over there. Then the palatal aspects of the maxillary incisors, and then maxillary sinusitis, maxillary molars, especially second premolar or first molar, and there is no clear-cut decay, and if the patient experience pain, it could be because of maxillary sinusitis. While doing a vitality testing, the vitality testing could be subjective, so you do not trust it 100%. Compared to the cold, heat and the electric pulp testing, cold testing is very, very reliable. Anesthesia testing and test cavity are not very reliable, and always pay attention to the discolorations which are present in the tooth, which may be a very subtle change, but we have to pay attention. Most non-vital teeth may have small color change differences compared to that of the adjacent teeth. And congenital defects like dens invaginatus, radix entomolaris, and maybe a C-shaped canal, we have to always pay attention for these congenital defects. And while doing a radiographic examination, whenever the tooth has a crown, always go for a bite wing radiograph. Never forget to take a bite wing radiograph. Whenever there is a trauma, never start the treatment without taking a radiograph and a proper radiographic examination. If there is a previous history of trauma, then always look for open apex, root fractures, or you have to look for the angulous tooth, or we may have to look for root resorptions. And whenever there is an orthodontic treatment which has the patient had undergone, always look for the shortening of the tooth length. There may be some form of resorption, it would have happened. And the dents invaginators, we have to pay attention. The maxillolateral incisor, actually the incidents are more than what is actually reported in the literature. Mandibular first premolars, the enigma to endodontist. The root canal treatments are very easy, or it could be extremely difficult, and without a proper diagnosis, if there are 2 roots or 2 canals, and if you have started the root canal treatment, it will be very, very difficult to locate the canal without a good preoperative diagnosis. Radix entomolaris and the radix paramolaris. Entomolaris is very, very common. Always pay attention for all mandibular first molars, and C-shaped canals are quite common in mandibular second molars. And we should always go for a CBCT examination whenever we cannot make a clear-cut diagnosis with all these procedures. Then whenever we are planning for a retreatment, or whenever there are some form of congenital anomalies, and if there are some procedural errors, in all those situations we can go for CBCT. CBCT is really helpful even in case of calcifications. So we have come to the end of this diagnosis in endodontics. I hope this 2-part lecture on the diagnosis in endodontics is quite helpful for anyone who have started with their clinical practice, especially in case of young dentists. But trust me, if you are good with diagnosis, your patients will start trusting you, and your treatment will be counted, and you will become a glorious dentist with a master in diagnosis. So I wish that be a master in diagnosis. Everything else comes next to the diagnosis. So first step in being a successful dentist is to master the art of diagnosis. Thank you for watching till the end of this presentation. Have a nice day. Next week I will come up with another presentation. Until, stay happy and do more root canal treatment and save the teeth. Keep your patients happy. Have a nice day.